So this is a little bit of a different focus than last week. Last week was more of a sort of introduction and sort of create a baseline so that I can be confident that you're at least to that point. So today what we're going to talk about is how to manipulate patients into centric relation. It's a very, very difficult thing. It is, in my opinion, probably the most difficult part of making a splint for someone. It is, in a lot of ways, those of you who have maybe observed people taking records for dentures, I think it can be one of the most difficult parts of the denture process. So there are a number of ways throughout the ages that people have tried to capture centric relation. Some people would do it just by having the patient bite. Any golfers over here? Any golfers? Okay. So when you golf, and I'm sure those of you who aren't golfers have seen this, when you play golf, you stand in front of the ball, except not like with your club at the ball, and you take, like, depending, 2 practice swings. If you play at some country clubs where people feel like they're doing this for the Masters tournament, they might take 20 practice swings. Those of you who golf know exactly what I'm talking about. It's very frustrating when you're behind them. But what they're really trying to do is build in muscle memory, right? What is the path of the club? What is the speed of the club? What are you doing with your hips? And that's what the practice swing is designed to do. Well, unfortunately, our muscles of mastication have that same muscle memory, and it's all driven by the PDL and the nerves within the PDL, so that if you have a tooth that is interfering, many times you won't notice that because your muscles of mastication close into MIP without actually striking the inclines of the cusps. Because if they did, you might feel pain. And so your muscles just say, don't bite there, bite here. And you get very used to biting in a certain place. So obtaining centric relation in that way is probably not going to be the most accurate, although it's a great way to get to the maximum intercuspation bite. Swallowing is another technique that people have used. Just said to the patient, swallow and hold here. That kind of holds true for some, but for others, for many, in my opinion anyways, at least my experience, it's similar to the maximum intercuspation bite. People are just used to swallowing, occluding their teeth in a certain way, so that's where they're going to go. When I was in school, most of the folks would teach chin point guidance, which is basically just putting, and you'll see a picture of that, it's basically just putting your thumb on the chin and driving the mandible posteriorly. Well, that's not a great way to do it either, because if you recall from the definition of centric relation is the most anterior superior position, right? Because the masseter muscle pulls the mandible anteriorly. And so just driving the condyle backwards, posteriorly, tends to drive it too far back. There is a technique with an anterior jig, deprogrammer, similar to exactly like what you'll be fabricating later. And that probably has a little bit better result because you're going to utilize anterior disclusion and then the muscles of mastication to position the joint. So there is a certain amount of accuracy with that as well. So chin point guidance without a deprogrammer, not so good. Chin point guidance with, remember it's guidance, not driving, is a little bit better. The next one on the screen is the MYOMONITOR. Some people call it a TENS unit. It's basically stimulating the nerves in the muscles, the jaw closes, and that's your position. Well, the problem with that is that it doesn't really take into account the joint. It's really all about the muscles closing. And some people feel that that's the appropriate place to treat patients. The next one down is a leaf gauge. A leaf gauge, I think, did we talk about that last week? It's basically just a a series of sheets of plastic about the width of 2 central incisors placed in between the teeth, and the patient bites on the leaf gauge. As you remove leaves from the gauge, the teeth come closer and closer together. The idea is, once you remove enough leaves, you're going to have the patient contact in an interference, or they're going to be an MIP. The only way for them to really be an MIP would be if you took all the leaves out, right? So if you get down to 1 leaf and the patient says, no, I'm not contacting any place, you pull that last leaf out, now they close, you could assume that centric relation was coincident with maximum intercuspation. Does that make sense? The problem with this, as you'll see a photo of it, is that some people argue that it tends to drive the mandible posteriorly, much like chin point guidance, and you'll see why when you see the photo of it. Bimanual manipulation, with or without an anterior jig, has been shown to be the most reliable, the most consistent way of positioning a patient into centric relation. I've given you, and I just posted these at lunchtime, so if you haven't seen them and looked and you haven't seen them, it's because they were posted just recently. But there are 3 additional articles that you might find interesting. One of them is which method is most reliable. Okay, so there's chin point guidance. And you can see it's just, I like the hand on the top of the head. It's like I'm going to push you backwards, but so that I don't push your whole head backwards, I got to stabilize your head. Again, I'm not a big fan of this. We did this in school. Not really what's being taught right now, I don't think, in too many places. You could slip a Lucia jig or a deprogramming jig in between the teeth, and with gentle guidance, it would be a little bit more reliable. MYOMONITOR gives you a readout like this. Seems like a lot of effort. When you do it the way we're going to show you today, I think you'll find it's a little bit easier. You don't have to hook your patient up to such a bulky machine and all that, and it's pretty reliable and has been shown to be even more reliable than the MYOMONITOR. Although there are a lot of people who follow this technique. And there's the leaf gauge, and you can see why when the lower anterior teeth contact that leaf gauge, it would drive the teeth backwards posteriorly because it's an inclined plane, right? And as you squeeze on that inclined plane, the direction of travel of the mandible is going to tend to be posterior. So you have to be very, very careful about instructing your patient not to bite very firmly on that leaf gauge. This is an anterior jig. It's developed by a gentleman by the name of Lucia. 1964, he published an article, and I've included that article for you. I know it's old. It still is relevant today. So this one in particular is something that you buy. So if you look carefully, you see the white, the very white, stark white bit of this. That's the jig itself. The material underneath that is just a material that is allowing it to form. I'm not really sure what this material is. It could be just PVS, which is kind of what we're going to do next time when you do actually take your bite record. This jig is very flat on the bottom. When we make ours today, you may not quite get it this flat. This is the goal, though. So kind of put this in your memory. This is what you're striving for. This one really goes posteriorly, so behind the central incisors, it really extends quite a ways. It's a store-bought thing, so it's got to accommodate pretty severe class 2 bite relationships. I'm kind of hoping that none of you have this much of a severe class 2 bite relationship. If you do, we're going to have to modify our jig perhaps a little more than we're going to do so today. So the manipulation technique, and this is really just showing one side of the technique. It's bimanual, so you're going to use 2 hands, but this is sort of a sagittal section through the mandible. Notice the direction of pressure. And it really is very gentle pressure. Pete Dawson used to speak of it as romancing the mandible. If you apply too much pressure, the patient will fight you, will activate the muscles, and you will not get centric relation. And you will struggle, and you will keep yelling at your patient, relax, relax. It's not going to do any good. So notice, let's see, maybe green. Notice the direction of this arrow right here. So this is your thumb, and it's pushing down on the symphysis of the chin, and you're moving your fingers upward. And this will get a little bit more clear as things go, but it's really a rotation, because remember that the muscles of mastication are pulling generally in this direction. Right? That's the masseter. The temporalis comes through, attaches here, and sort of pulls in that direction before it curves posteriorly. So the rotation is this way. You're placing pressure downward with your thumbs while lifting upward here. The net result is the joint is following that red arrow up by the condyle. Does that make sense? So while you're manipulating your patient today, that's what you should be thinking in your mind, that motion of rotation of the mandible. Okay? So let's just practice for a second. Hands like a C. Position them like that. Tips are curled, thumbs are curled. A lot of times I see thumbs out straight, looking like this. Everybody see that? Notice, everything's curled like a C. Okay? Does that make sense? The symphysis is located. I like to put my little pinky sort of behind the angle, just barely behind, so you can just feel that. I will caution you, there is a nerve and blood vessels that course over. Remember the inferior mandibular notch, that little area right there? Remember that? That's where the nerve, facial nerve, courses through. You don't want to pinch that. So you can feel for that notch. Make sure your fingers are either side of that notch. It's a little uncomfortable when you put a little pressure on the patient in that area. So the fingers are located as such on the angle, not on soft tissue. You want to be on that hard inferior border, right? You can feel that on your own jaw. That inferior border is very hard. There's very little tissue there. It's just skin and a little bit of fascia, right? No muscles. You're not going to be really putting a great deal of pressure on any sensitive structures. Okay? And that's what it looks like. Any questions so far? Okay. Another angle. Okay. So here's kind of what the whole thing looks like.
So the first thing is we've got a Lucia jig ready to go. And it's already painted with adhesive. And so we're going to go real close up here on the monitor as well. So we've got the Lucia jig already painted with adhesive. And as we talked about yesterday, we're going to load up a bunch enough to go around the edges, but not too much. And then John Day's going to have the whale tail ready to go. So we're going to put this right on Don's incisors here. So we have that's okay. Of course. We're going to put the whale tail on. Go ahead and like you're biting on the edges of your front teeth come together. Beautiful. And what that does is creates a nice horizontal plane with her lower incisors.
Yeah, I'll kind of narrate through. I think that might be a little bit better.
In fact, it's quite quick. And now our goal when we take it out is to just make sure that we don't have lower incisors touching as we talk.
Okay, so he's just fabricated the Lucia jig. I've kind of started this in the middle of this video. When you pop it up on your own, you can watch the whole thing. There's a bunch of other techniques towards the end. I didn't really want to show that, but I urge you to watch that. So he's just fabricated the Lucia jig with PVS material in it, relined it, and there you have what that's going to look like, right? This will make a little bit more sense as we go, but I did want you to see what this looks like here. Okay. And he's just pretty much talking right now, but he's going to start manipulating. Patient, he's going to just mark that area and have the patient protrude, because the goal is to have one point of contact. So it should be a lower incisor on that jig, one
is
point
you've
of
got one
contact,
great mark right
not
there.
two.
And you can
Just
see
pick
as
any
the
one of
slide
the
comes
lower
together,
central
it slides
incisors
forward
and
back
just have one
and
point of
forward
contact. The
and
patient should
back.
be
What's
free
the
to
only
go
thing that's stopping her that we talked
anteriorly
about
and
yesterday? What's the
posteriorly
only thing that's
with the
stopping her
mandible.
right
And
now?
you see the mark that's created
Unless she's
on
got a
that
hot
jig.
lateral pterygoid, the ball is in the socket. And
Some
we
of
wanna
this is for
verify
next
that she's
time,
touching that
which is
point
this.
on
We're
the
not going
record,
to
so
we're
we're
not
gonna
going to
switch
use
to
our
the red
jigs
piece of
today.
tape here. And Don, just like you're trying to bite on your back teeth, I'm going to have you open for me. And just like you're trying to bite on your back teeth, just a couple
Mark
of
it again.
And open for me now. And again, what you can see, and we can come in real close here now, Jennifer. Let me tip up just a bit there. You can see that red mark right at the end of the black stripe. And so in just a second, Don, we're going to load up some goop in through here. I'm going to ask you, just like you just did, to bite on your back teeth. I'm going to watch you like you're trying to bite on your back teeth. Go ahead and do that one more time for me.
Now this patient obviously is very easy to manipulate into this position. He doesn't have his hands in the appropriate position yet. You'll see he'll change.
2x2 here. We're going to go ahead and dry.
Okay,
Now,
so
again,
he's
don't
actually
forget, we
taking
had
the
to
bite
look at
record
how much space
right
was
now.
back there. In fact, before we do this, bite together one more time for me.
Or he will be in a
Gotta
second.
Take a look at how much space. I'm going to have you tip your head down just a little bit. How much space is back there? And so when we're putting the material in today, we've got to make sure we fill that much space, and we want to make sure we go all the way.
So you can
buckle
sort of
around
hear
the
him. He's
cusp of
talking
this
about the
side.
amount of space that's present.
go ahead and
You
dry
want
your
a
top
fair
teeth.
amount of
And I always go
space,
top teeth,
but
that
you
way it
don't
keeps
want
the
the
tongue
patient
out of the
so
way,
open
so
that
we
they're
don't have to worry about it
translating,
getting in the way,
right?
right?
You don't want their mandible
We're gonna be
translating.
pretty
It should all be
efficient with this.
in the
I'm gonna start back
rotational
on second
zone
molars.
of movement. Okay.
I'm going to make sure I have
He's going to
enough
now
thickness of material
place
all
the
way up to
bite
cusp.
registration material.
I'm gonna
This is
come to the other
PVS.
side, second molars, covering buccal and lingual cusps all the way to the cuspid. Just
And
like
then
we did
you'll see the
before, Don, if you would like
manipulation.
to jaw drop back
Now
and
he's
forth,
going
you
inside
can
the
bite
lip,
on your back teeth.
and he's not really manipulating in
see
the
that she's
exact same way.
exactly
But
where she
again, this
was.
patient's very
And
easy.
are you
to do.
absolutely sure that right now
More
you've got
difficult
a bite
patient,
record
he
in
would
a
need to
fully
be in a
seated
different
position?
position
I'm
than that.
dead sure.
Okay.
And it's really just, and it's just that efficient. It's that great.
And
It
then
doesn't take
he
too
just
long
sits
to
there.
set up.
The purpose of the Lucia jig is to allow the mandible to move in any direction. Okay, that's purpose number one. Purpose number two of the Lucia jig is to allow the patient to be stabilized while the PVS sits. Some people use wax to record this. I did this most frequently in practice. I just used wax. With wax, I didn't really need a jig. I had gotten pretty capable of manipulating most patients into CR. I just used wax. There's a technique that goes along with that. I think he might even have that here. Wax hardens very quickly because it just cools, and so you don't really need to stabilize the patient's jaw. You're just recording into the wax. With PVS, you can imagine trying to hold the patient slightly open for the minute or minute and a half that it takes for this bite registration material to set. That patient or you are going to be moving the mandible, and you're really going to distort the actual bite record that you're getting in PVS, right? So that's the second purpose of the Lucia jig. Now, he commented on the amount of space that's present between the arches. That's important because PVS bite registration material is more accurate than alginate, so you need to have enough bulk of PVS material so that you can trim it. Some of you have probably already seen this in clinic, right? You're mounting something in MIP, or you're taking an MIP bite record. The student clinician places PVS on the teeth, asks the patient to close. MIP, tooth-to-tooth contact. You take the bite record, you can hold it up to the light, you see dots through it, right? The problem with that is that you have incredible detail of the teeth that you might not have in your alginate, right? So it looks like this. The white, let's say, is the alginate reproduction of the teeth. The red is the PVS reproduction of the teeth. The PVS reproduction is more accurate. Notice how in the central fossa, the PVS has captured that central fossa really nicely, but it can't fit into the alginate. So if you move that red line down in the central fossa, it's going to move just a little bit, and you can see over the cusp tips, you won't have contact, right? Does that make sense? Because of that, your PVS bite record is not fitting the model accurately. And so your mounting will not be accurate. So what do? You lop it off. You trim the bite record, okay? And again, another short little video of trimming the bite record. Whoops, sorry about that, guys.
In this vlog, we're going to look at trimming silicone bite record, which I use routinely to mount both diagnostic.
So you're just going to use a sharp scalpel blade.
One of the ways
you're going to lop off the material that extends beyond the buccal and lingual cusps. Just like that. Be careful you don't cut yourself. I would urge you not to use a 12 blade. That hook just really doesn't help your thumb as you drive it into it like that.
To 1 millimeter of overlap.
Ask me how I know.
On the buccal and lingual sides of the teeth.
And then you cut the interproximals,
now be used to
as you see here.
That flowed interproximally, as well
and
as
then you cut the central fossa.
Any place
all you really need are the cuspal indentations, because that's going to be, with alginate, the most accurate part of the model. And so you want the PVS to fit. When you replace the PVS onto the cast, because you've cut the buccal and lingual, you should see no space between the PVS and the stone cast.
On both sides of the record, maxillary and mandibular. If I have excess material that's gone beyond...
Everyone understand so far? Are we all good? Any questions? Nothing. Nobody. Fantastic. Crystal clear. Picture's worth 1,000 words, a video's worth even more, right? Okay, so we got another one. So this is going to be the exercise today, and it's not much of an exercise. You'll see it's pretty simple. It's going to take you, I think I put the video together in 7 minutes, but I knew what I was after. It might take you 10. It's not a big, long process. So just wait for it. It will start, I believe. There's a little bit of space there at the beginning. Okay. So Stephanie has nicely cut strips of wax for you, and she has cut the triad material as well. So you will wrap 2 layers around. I just did it this way. I wrapped it, folded it over the centrals, cut it off, and now I've got 2 layers of wax covering both centrals. Just like that. Pretty simple. Piece of cake, right? I'm asking you to do this in your mannequins because in the clinic, you may or may not have a model of your patient. If you had a model, you could do it on the model. If you don't have a model, you can do it right in your patient's mouth in virtually the same way that you see here that you're going to do it. Okay? And then you're going to take your triad material, fold it over. Some of you are working already, but you don't have your PPE on. Sorry, right? Isn't that what we do in sim clinic? Sorry, guys, you're working in the mouth. No PPE. I got to call you on it. Okay, so now you got that. You light cure it. Light cure the exterior. I didn't show you, but I took this off, took the wax out, and I light cured the interior. You don't really need to use the triad light curing units that are in the other part of the lab, in the wet lab. Okay, and then this is as close as I can come to a centric relation position on this little sim patient here. But that's what we're after, okay? So a couple of principles. First is when you make this jig, you saw the Lucia jig, the store-bought one, right? It was perfectly flat. That's ideal. I'm not quite as concerned about that, but what I am concerned about is not having an inclined plane. So that means the lower incisors have to contact this jig that you make at a 90-degree angle. Now, this is sort of we're just making a generic thing, right? You could conceivably make this right on your patient with no wax in between. I'm really scared about you guys doing that in the mouth, because if you press this triad material in too firmly and the patient has some undercuts on the tooth or teeth, you will lock it on once you light cure it. And I personally don't want to be having to pull out a handpiece to cut this off on someone's front teeth, because if I touch that enamel, it's not a good thing. So you can do it that way, but I would probably say let's not. Let's use wax in between if you're doing it in the mouth. Using that wax spacer is great because the bite registration material will lock this on real well. So we're going to make that over the next half hour or so. It's not even going to take you that long, I'm pretty certain about it. We'll show you once it's all made. Before you leave, we can trim it up a little bit because some of them might be a little rough around the edges and whatnot, because these will be used in the clinic, not today. Today's exercise is really geared to just having you manipulate as many of your classmates as possible. We're going to go into a clinic, and I want you to manipulate as many people as possible. You will find that everybody's different. When you're the patient, please help your fellow classmates. Everybody will have a different pressure, a different position, right? Some of you don't even know that you have centric relation interferences. You will find that out today. Please help your classmates understand what they're doing, whether they've got it. You might quickly learn, oh, I have an interference. That's where it is, because every time it goes there. And then the next person comes along, and it's not there. Help that person out. What are they doing differently that's not allowing you to be positioned in that appropriate CR? CR is very repeatable. You will be amazed at how repeatable it is. We just want the manipulation today. No jigs, because then you got to make new ones because you're going to put them in someone's mouth and you can't put them in somebody else's mouth and all that, right? So when you come to the clinic next time, you'll be taking impressions, face bows, and using this jig. You will want to have sprayed it. So upstairs, we have spray. You'll spray it down just like you were disinfecting an operatory, right? Just soak it in spray. It's got to sit there for 3 or 4 minutes or something like that, right? Wes? You mean too thick. So the question was, for the purposes of the video and the audio recording, is it possible that this jig will be too wide, but really it's too thick for placing the patient in CR? Remember that CR is a joint position, right? And it's CR along that whole path of rotation, right? So MIP really doesn't play into a factor here. It's not, MIP isn't a factor. We're actually striving to not find MIP. When patients go from MIP and you try to put them in centric relation, sometimes it's very difficult. Why? Because of muscle memory. And when you try to put them into some other position, that's when they start fighting you. So one of the tricks we have is to use a Lucia jig, right? Today we're not going to do that, but if you had a Lucia jig, you could just put the Lucia jig, walk away, go to your hygienist, do the exam, go to your next hygienist, go grab a cup of coffee, come back, and now you're ready to manipulate your patient. Why? Because for 10 minutes, your patient hasn't been in MIP. You've destroyed some of that muscle memory, so now it's a lot easier to re-find their actual centric relation position. As far as the thickness goes, when you place it in your partner's mouth, and today we're not really using partners. We're going to pair up. We're going to quadruple up today. We're going to have you in groups of 4. Next time you'll be paired up, and I think you've already been paired. Is that correct? My understanding was you've already been paired for this class? No. Okay. That came secondhand through Dr. Ferrier. So I will check with Dr. Bond and Dr. Candlewall and find out if there is a pairing planned. If not, maybe there is and you just don't know about it yet. But you will place the jig in your partner's mouth with PVS material, bite registration material, and you will find that you can move that Lucia jig a little bit in your patient's mouth. Yalda, question. The wax will be removed for use. The wax is simply a spacer to make room for the PVS bite registration material. So the question was, will we remove the wax? And the answer is yes. The wax is simply a spacer because you need place for that PVS material. It also will allow you, the other reason I use 2 layers of wax is because I want to make this oversized, because some of you will have squared anteriors, right? The anterior will be flatter. Some will have maybe very curved. You may need to cut the edges of it with a handpiece, and we'll show you how to do that in a little bit. Other questions? Yes.
Can you describe how centric relation feels?
Sorry?
Can you describe how centric relation feels? Like I've never done it.
You haven't done it, right? And that's why you're going to do it today. So I could try to describe it. It's really, what you'll find is generally it will just slide in. And when you're there, especially after you've done this a few times, you will know when you're pretty darn close. And that's the reason that I want all of you to do this on as many of your classmates as possible, because it feels different for a lot of people. And once you get the feel for what it's doing, it's going to be a lot easier. What we're going to try to do, and I've instructed the faculty, we're going to try to identify of the first group of 8, because I think we're maybe going to have 8 or 9 groups in a clinic. Once we identify those patients, students, that are easy to manipulate, we're going to try to have you all work on an easy one. Because once you work on an easy one and manipulate an easy person, then the more difficult people who are going to fight you, and I guarantee you're all sitting there going, nah, I'm not going to fight, I'm not going to fight. I guarantee you, it's probably going to happen. It's just, out of a group this size, someone is going to fight. But once you get the feel for it, that question will be answered just by doing. So the question is, if we take out the wax, how will it be stable on those anterior teeth? You will paint the intaglio. Everybody know what intaglio is? You will paint the intaglio of the Lucia jig with adhesive, place bite registration material, and while the bite registration material is soft, you will seat it over your patient's 2 anterior teeth, stabilize it, and let it harden. Once the bite registration material is hardened, now you'll be able to move it on and off, and you'll have a nice stable place for it. When you mount your casts, you are not going to use the Lucia jig in the mounting. The Lucia jig is not used for mounting the casts. The PVS bite registration material alone will be used for mounting the casts. Okay? Other questions? All good questions. Really good. Nice engaged group. Terrific. Yes, Dr. Bond. Okay, perfect. That answers that. Terrific.